I will be talking today about the whole genome sequencing in critically ill children, and my talk will be focusing on implementation of rapid whole genome sequencing at Nicklaus Children's Hospital. Genetic disease, unfortunately, is the leading cause of death in NICU, PICU, and CICU in the hospitals. And out of 10,000 daily US births, about 64 children dying before their first birthday. And often that even happens without receiving a genetic diagnosis. In our project, we focused on children in critical care environment who are in a hospital, and physicians sometimes don't know what exactly is happening with a child. They suspect some genetic disease, but don't know what specific diagnosis it is, and don't think that standard genetic testing would help them. This program aims to provide diagnosis of rare genetic diseases to these children. And we think it's important because often if timely diagnosis is not done, these children go on unnecessary and lengthy diagnostic odyssey. They receive unnecessary tests and often also have irreversible harm. In our study, we compared two scenarios. First one is kind of standard of care where kids are admitted to critical care environment and are not going on rapid whole genome sequencing testing path. They receive standard testing. In this case, between 10 and 20% of children receive diagnosis. The rest just get empirical treatment and often additional tests and procedures that may be not necessary. And majority of them go on a diagnostic odyssey that can take years before they actually know specific diagnosis. In our program, we offer rapid whole genome sequencing that takes 3 to 14 days. And about half of the children get genetic diagnosis, and 44% of these kids also get some kind of change in management. The examples of changes in management are below in this pie chart. We had one liver transplant avoided, one heart surgery avoided. About 20% of kids had medication adjusted or follow up with specialists. About 25% kids got additional labs or tests performed, and about 20% also get therapy for metabolic condition. In our experience, receiving rapid whole genome sequencing accelerates the diagnosis on average by 5 months and also improves family satisfaction and reduces costs. This is one example of a case that we've seen here at Nicklaus. A 2-day-old baby boy was admitted to the neonatal intensive care unit. Among other issues, baby was unable to feed, developed severe metabolic acidosis, and also excessive amount of fluid in lungs. After a few days, we received the results of rapid whole genome sequencing and found mutations in 3 genes. And the UFA1 gene helped us to diagnose a severe neurological disorder, complex I-deficient Leigh syndrome. And fortunately, there is a treatment, surprisingly very simple, with B vitamins and the antioxidant that may help manage this disease. The second mutation was in SCN1A gene, associated with spectrum of seizure disorders. At the moment, baby was not presenting any symptoms of seizures, but this would help physicians to monitor this baby. And the third gene, CHEK2, is associated with higher susceptibility to breast and colorectal cancer. This mutation was actually inherited from baby's mother, which also triggered genetic consult with mother and will help her also monitor her health in the future. So this way it also benefits mother of the baby. As part of our pilot project, we also performed open-ended interviews with the caregivers of these children. And we were interested in understanding how well parents understand the results, the utility of the results, and also how do they feel about it. We found out that 20% of caregivers actually had clinical depression, and 43% of these parents had anxiety. That was not very surprising because this is a very stressful situation when your child is in critical care unit and nobody knows what's happening with the baby. But it was helpful because we were able to refer these parents to seek help and consult with psychologists. We also found out that pretty much every family has been through a roller coaster of emotions, and they needed social medical support. And everybody expressed satisfaction with the process. Some of them actually found that these interviews were therapeutical. These are some citations from the parents. It's a beautiful experience because we can also find out what we have. I felt quite comfortable because it's something that leaves you at peace to know that the test is quite comprehensive. I would love if in the future the insurance companies would support this because there are truly kids who need this and parents who can't pay for this. We also looked at the demographics of parents and families in our project Baby Manatee. And interestingly, says that my internet connection is not stable. Interestingly, patients in critical care environment were very different from patients who go to outpatient genetic clinics. So here on the left side, you see demographics for patients who go to outpatient clinic and are on Diagnostic Odyssey. They were more frequently white, less frequently Latino, Hispanics. They more often had college degree and earned more than $100,000. They had more frequently private insurance and less frequently Medicaid. The critical care environment population actually reflects our hospital population more closely. Our hospital population is about 60% Medicaid and predominantly Hispanic. And when we think about reasons for these differences, we have noticed that families who more educated tend to follow up with the geneticist, and families in minorities, they actually often lack knowledge and awareness about genetic testing. They don't get referrals to geneticists. They often don't have time to travel to outpatient visits. And sometimes there's also mismatch between the providers and their own culture and language. So they actually less likely to get genetic diagnosis if, if they're not in critical care environment. We also performed health economics analysis because we would like this test to be supported and paid by payers and insurance companies. And as you can expect, most insurance companies don't pay for that. And they really would want to see data. So we compared patients from our rapid whole-genome sequencing group with entire critical care patient population. So we have about 1,000 patients a year who come to NICU, PICU, and CICU. We selected patients who received standard genetic testing, and when we looked at the costs and cost savings, we found that we actually have about $100,000 savings in cost for payer if rabbit whole genome sequencing is used. It's also important to say that rabbit whole genome sequencing only would benefit small proportion of critical care patient population. So in our experience, it's about 3%. And these children are usually kids with multi-system problems, and they don't really have a specific diagnosis. So it's not just isolated prematurity. It's not any genetic disease that is easily diagnosed. So this is a very specific test. And we calculated that just in Nicklaus children's alone, payers would save about $3 million per year if this test is supported. So in summary, rabbit whole genome sequencing really benefits all three dimensions. It improves health outcomes, improves clinical experience, and also offers cost savings. Unsurprisingly, some payers pay attention to that and are really open-minded, and mostly these are Blue Shield, Blue Cross in different states. You can see Blue California, they support this test, Blue Shield, Blue Cross in Louisiana and other states. They recognize medical necessity, but it's still really challenging to get the reimbursement. So we're working with ACA here in Florida, showing and sharing our findings with them. Hopefully this test will be supported in the future and will be a standard benefit for kids who really need it. The only state where Medicaid has started to pay is state of Michigan. They just started it in October. And Medi-Cal in California also added it to their agenda, and they are preparing to support it starting in January 2022. So I would like to thank Cornelia T. Bailey Foundation, Florida Department of Health, and Sanford Children's Genomic Medicine Consortium that provided funding for this testing. And of course, the Nicklaus Children's team and University of Florida Health Economics team. And it all would not be possible without Rady Children's Institute for Genomic Medicine. All rapid whole genome sequencing was done at Rady Children's. Thank you.